A very good afternoon to all my colleagues and friends present here. Today I'll be talking on the effect of modern epidural on maternal and neonatal outcome. What is the current evidence? Now, as we all know, when you go back in the history of labor analgesia, there was immense reluctance in acceptance of labor analgesia, both by the caregivers as well as the caretakers. That means the anesthesiologists, obstetricians, as well as the patients. There were many reasons behind it, such as it prolongs labor, interferes with the urge and ability to push, it causes increase in the instrumental and cesarean section rates. Other causes such as it causes maternal hypotension, increases the risk of fetal distress, maternal risks and complications such as backache, infection, neurological impairment, and so on. Overall, it interferes with the natural childbirth process. Last but not the least, it has negative effects on maternal bonding, breastfeeding, and parenting. These were the myths that obstetricians as well as the patients had, and that is why the reluctance in the acceptance. Now, over the years, after doing a lot of research and studies, now what we have is modern epidural analgesia. It has overcome these challenges and avoids unwanted effects. We have best tried to balance the maternal satisfaction with the newborn neonatal outcome. Unfortunately, this information is still not well disseminated to the large audience that includes women, families, midwives, their doctors, obstetricians, and even the anesthesiologist. Now, what do we actually mean by modern epidural analgesia? It means analgesia on maternal request, and you don't have to wait for 4 to 5 centimeters of dilatation, which was earlier believed. Ultra-low dose of local anesthetic agent, using combined spinal epidural, patient-controlled epidural analgesia, and of late we have computer-assisted injection of epidural solutions, which is still under research, and ultrasound-guided neuroaxial techniques are very well established, especially in North America. Now, the parameters for maternal outcome are analgesia, satisfaction, instrumental delivery rate, cesarean delivery rate, duration of labor, and other factors such as ambulation and the use of oxytocin. First, we come to the timing of initiation of neuroaxial analgesia. We all know that American College of Obstetrics and Gynecology for many, many years recommended women delay requesting labor analgesia until 4 to 5 centimeters of cervical dilatation. So the question here is, does early initiation of neuroaxial labor analgesia affects labor outcome adversely, or it is merely associated with increased risk of cesarean delivery? Two randomized controlled trials done by Chestnut, he did it on primigravidas, on spontaneous labor, and those with oxytocin augmentation. He divided them broadly in two groups. Group A was who received early epidural analgesia, and epidural was started in them when they were about 3.5 to 4 centimeters dilated. The second group received early intravenous opioid, followed by epidural analgesia when the cervical dilatation was about 5 centimeters. He found that there was no difference in the cesarean delivery rates. Another study, which was done by Wong and O'Hill et al., these couple of studies also showed similar results. They initiated epidural at cervical dilatation of 2 centimeters, and they found no difference in the rates of cesarean delivery and also instrumental vaginal delivery rates. As a result of these studies, in 2006, the American College of Obstetrics and Gynecology published an updated committee opinion entitled Analgesia and Cesarean Delivery Rates. And it stated very clearly that in the absence of medical contraindication, maternal request is a sufficient medical indication for pain relief during labor. The fear of unnecessary cesarean delivery should not influence the method of pain relief that women can choose during labor. This was seconded and accepted very well by Royal College of Obstetrics and Gynecology, Royal College of Midwives, Royal College of Anesthetists, and Royal College of Pediatricians and Child Health in 2007. After that, a number of studies were done, and one very interesting randomized controlled trial was done by Wang and his colleagues over a 5 years period on more than 12,000 nulliparous parturients. And they found that the cesarean section rates were quite similar, about 23% when the epidural was used in latent phase or in the active phase. Again, Wong and his colleagues in 2007 published in Anesthesiology that when epidural was given at cervical dilatation of less than 4, the cesarean section rate was about 32%, and when it was given at cervical dilatation of more than 5, it was about 31%, so the results were quite similar. The meta-analysis of 8 randomized controlled trials and cohort studies of early versus late labor initiation of neuraxial analgesia in more than 3,000 women also showed similar results. The bottom line is there is no increase in the cesarean section rate with the use of neuraxial analgesia. Now, thus, the lesson that we take from this is early institution of epidural analgesia in labor has distinct advantages for maternal analgesia as well as satisfaction. Now, next we come to neuraxial analgesia and instrumental vaginal delivery. 2 very huge studies were done in Tripler Army Hospital and National Maternity Hospital Dublin. Both were teaching hospitals. And they found that despite a large increase in the rate of epidural analgesia from 10% to 80%, there was no change in the rate of instrumental delivery. It stayed at 11%. Siegel and colleagues found in their systematic review of 7 impact studies in more than 28,000 parturients that there was no difference in the instrumental vaginal delivery rates. Now, contrary to this, there were 3 very good studies which came in about 2005 by Halpern, Sharma, and Liu, where they said that there is an increase in the instrumental deliveries with neuraxial analgesia. Now, these conflicting results emphasize the potential impact of the confounding factors. What are these confounding factors? First, there is density of neuraxial analgesia during the second stage of labor is important. If there is a dense sensory block, it would decrease the expulsive efforts and would relax the abdominal wall of the wall muscles of the mother. It also decreases the maternal effort to coordinate expulsive efforts with the uterine contractions. A high local anesthetic concentration would obviously relax the pelvic floor and interfere with the fetal head rotation. Obstetricians are more inclined to use instrumental vaginal deliveries in those with effective second stage analgesia. I think we all must have observed this in our own institutions. It is interesting to note that controlled trials were performed in the teaching institutions where the teachers are obliged to teach the trainees how to use forceps and apply vacuum, whereas the impact studies were done in the non-teaching institutions. Now, adding more confusion to the topic is the fact that degree of neuraxial analgesia is in turn influenced by several other factors such as analgesia technique, local anesthetic concentration, and the anesthetic dose that overlaps when you troubleshoot. It's interesting to note that the incidence of instrumental vaginal delivery has not been assessed as the primary outcome in any of these trials. Thus, the dosage and the drug delivery systems were studied, and Smedstead and Morrison found a very high incidence of instrumental delivery with continuous epidural as compared to the intermittent bolus technique. They also found that a high dose of bupivacaine of 0.25% had a higher rate of instrumental deliveries as compared to 0.125% bupivacaine and a dose lower than that. Whereas Wong and his colleagues found that there was no difference in instrumental vaginal delivery rates with low dose bupivacaine fentanyl. If you use it either by intermittent or continuous, it doesn't matter. A low dose would not increase the instrumental vaginal delivery rates. Another meta-analysis published in the British Journal of Anesthesia, where they compared the patient-controlled epidural analgesia without background infusion versus the continuous epidural infusion. And they clearly found that in the patient-controlled epidural analgesia group, the lower bupivacaine dose was used and there was lower degree of motor block. There was no difference in the rate of instrumental vaginal deliveries. So they concluded that a low-dose bupivacaine and a PCA for maintenance is preferred to prevent instrumental vaginal deliveries. Now next, we see the association between the neuraxial analgesia and duration of the first stage of labor. Again, there is no single randomized controlled trial which has investigated this as a primary outcome. It was all the result of the secondary outcomes. There were two meta-analyses, one by Halpern and Leighton and the Cochrane review in 2005. The results were that there was no difference in the duration of the first stage of labor in those receiving epidural analgesia or systemic opioids or no analgesia at all. Whereas Shiv Sharma at the Parkland Hospital in their meta-analysis found a prolongation of the first stage of labor by 30 minutes in nulliparous parturients, but it was not associated with any adverse maternal or neonatal effects. Contrary to this, Sen et al. Compared combined spinal epidural technique with epidural analgesia, and they found that there was faster rate of cervical dilatation with the CSE technique. Now, duration of the first, with regards to this, the available evidence suggests that the neuraxial labor analgesia has variable effect on the duration of the first stage of labor. It might either prolong it or it may shorten it. These inconsistent results are a result of influence of several factors known to affect uterine activity and the duration of the first stage of labor. Further investigations that need to control the confounding factors are certainly needed. Now we see the association between the neuraxial analgesia and duration of the second stage of labor. In meta-analysis by Halpern and Leighton, they found that neuraxial analgesia prolonged the second stage of labor by 15 minutes. There were several studies which suggested that though it was prolonged, but was not associated with adverse maternal and neonatal outcome, provided the fetal status is reassuring at all times, mother is well hydrated with adequate analgesia, and you avoid a motor block and the maternal hypotension, and you see a good progress of the fetal head descent. People's study is a very famous study which is pushing early or pushing late with epidural. They found that delayed pushing is associated with high rate of spontaneous vaginal deliveries, shorter duration of pushing, lower rate of mid-rotational forceps, and no adverse neonatal outcome was seen with this. However, in meta-analysis of 9 studies in 2004, the delayed pushing did not decrease the rate of instrumental or cesarean delivery, but it did decrease the rate in the mid-pelvic rotational forceps delivery. It appears that the delayed pushing does not impart any major neonatal or maternal benefits, although it seems reasonable to delay pushing until the fetus has descended to a lower fetal station to avoid maternal exhaustion. Now, it is very important to note this point. There has been an ongoing controversy whether neuraxial labor analgesia adversely affects progress of labor and method of delivery. We all have come across patients. One patient at 4 or 5 centimeters is very comfortable, is not having very severe pain. On the other side, there is a patient who is just 1 to 2 centimeters and just cannot tolerate the pain. What can be the reason? So it is possible that painful labor may be a marker for longer, more difficult labors. Independent of neuraxial analgesia, women with early and more severe pain have a higher incidence of instrumental deliveries and abnormal fetal heart rate patterns. Now, the modern neuraxial analgesia also includes ultra-low dose neuraxial analgesia, and in this section, we'll look at the combined spinal epidural and maintenance with the patient-controlled epidural analgesia. We are all aware of the benefits of the combined spinal epidural technique: faster onset, reliable anesthesia, high quality, maintained till the second stage, high maternal satisfaction. However, there are disadvantages like high incidence of pruritus due to subarachnoid opioid injection, fetal heart rate abnormalities, post-dural puncture headache incidence is high, and the lower limb motor block incidence is also high. But we still don't know what is the optimal drug regimen. To find this, there were a number of studies done, and Stock and his colleagues determined the mean local anesthetic dose for intrathecal bupivacaine with and without fentanyl. They found that with fentanyl, there is dose-dependent reduction in the dose of mean local anesthetic dose of bupivacaine, and there is prolongation of analgesia, but there is an increased incidence in pruritus. Camorcia and published an article in Anesthesiology in 2005 where they found greater analgesic potency for bupivacaine as compared to levobupivacaine and ropivacaine. Now, looking at association of intrathecal sufentanil with cesarean section, a retrospective study on 2,500 patients were done where the one group was the CSE group, which received about 5 to 15 mics of intrathecal sufentanil, and the other group received systemic opioids or no medication at all. The rate of cesarean section was very, very similar in both the groups. Looking at the PDPH rate, the dural puncture with CSE definitely increases the incidence of PDPH, according to Skupski and his colleagues. However, all trials reported approximately 1% incidence of headache regardless of the neuraxial procedure performed. This was in the Cochrane Database Systematic Review 2007, and they also stated that study with 80% chance of detecting an increase in the postural headache from 1.6 to 2.1% would need at least 10,000 patients per group. Now, as the incidence of PDPH with 25 and 27 gauge needles is low, the clinician's decision should not be based on this factor, and they should just look at the mother and the fetus. Now, there is something called as dural puncture epidural technique. In this, the earlier studies in non-obstetric population suggest a possible transfer of epidurally injected solution into the CSF through the dural hole, created during the CSE technique with an improvement in the epidural analgesia quality. Dural hole made by the spinal needle, but the anesthetic solution is injected only in the epidural space and not in the CSF, has been recently investigated by Thomas, and he did the study in about 250 parturients. His groups were only epidural and the dural puncture epidural technique. For DPET technique, he used 27 gauge 27 gauge spinal needle, and the epidural bolus of 10 ml 2% lignocaine was given. He found that the sensory level, incidence of unilateral sensory block, number of top-ups, and the PCEA volumes were very, very similar in both the groups. Now, against this, another study was done on 80 parturients, and this time, this investigator used 25 gauge spinal needle, and the epidural bolus given was 12 ml of 0.25% bupivacaine. He found the results a little different. The analgesia was very, very good, less than 10 by 100 at about 20 minutes post-injection, and he found that there was reduced incidence of unilateral block and increased S1 block. This variability in the local anesthetic used, and it was seen that the firm conclusions cannot be drawn because of this variability, and in the local anesthetic use, the drug concentration and the bolus size. Further research are definitely warranted to investigate this, to know the benefit and safety of this particular technique. Coming to motor block and maternal hypotension association, it was found that intrathecal bupivacaine 2.5 milligram causes greater motor block than the equal dose of ropivacaine and levobupivacaine. Okay, then bupivacaine, to conclude, bupivacaine has greater motor block potency intrathecally than levobupivacaine and ropivacaine, but at clinical doses for labor analgesia, incidence of motor block is low and should not be of concern to the clinicians. As you can see here, another study done by Robert Whitty from Canada, and it was published in IJOA in 2007. He used 1.75 milligram bupivacaine with 15 mics fentanyl in the CSE for labor analgesia, and he found no motor block in any of his patients. Goodman and his colleagues found more maternal hypotension with CSE, which was easily treated with fluid bolus and low-dose vasopressors. There was no maternal or neonatal morbidity which was seen. Another Cochrane Database Systematic Review 2007 concluded that relative risk of these adverse outcomes is not increased by any particular anesthetic technique. CSC or epidural doesn't matter. The clinician's decision to perform any technique should not be based on these possible side effects. Coming to continuous spinal analgesia. Now, continuous spinal analgesia consists of intentionally inserting a catheter through the dura into the intrathecal space. Do I have some time? Oh. Okay, then I'll have to hurry up. It was seen that cauda equina syndrome is seen in 11 non-obstetric patients. And the US FDA withdrew it from the market, but for investigational purpose it was introduced, and now it is restricted in UK for use only in a very highly selected patients. They found superior analgesia with this, with better maternal satisfaction, but higher failure rates because of catheter dislodgement, and very high rates of PDPH were noted. Coming to PCEA group, there is definitely increased maternal satisfaction, reduced physician workload, decrease in the breakthrough pain, which requires anesthetist intervention. It reduces the local anesthetic consumption and decrease in the motor block. It seems that the high injection pressure generated with the bolus results in more uniform spread of the drug within the epidural space. Now, looking at association of epidural and breastfeeding, there is no clear-cut relationship between the both. Another very good study done by Stephen Halpern, PCEA for labor, they compared they compared a lot of factors, background infusion versus non-ropivacaine versus bupivacaine, high versus low dose of local anesthetic, and new versus the standard strategies. And they found that excellent analgesia was seen with low concentration of bupivacaine. Motor block can be minimized if you use a dilute local anesthetic. A background infusion is suitable, and it reduces the need for further interventions. There is no ideal PCA setting. Looking at the association of oxytocin and labor outcome, there was no clear-cut association, but the ACOG supports oxytocin use for dystocia or arrest of labor in the first or the second stage, irrespective of the neuraxial analgesia. Now, I will quickly go through this. Cochrane database reviewed in 2010. We'll just see at the results. They concluded that women with epidural had prolonged second stage of labor, and need for oxytocin was there with an increase in the risk of instrumental vaginal delivery. The length of the first stage of labor is longer in the epidural group, but did not reach statistical significance, and it was not associated with any adverse neonatal effects. Now, whether an increase in the duration of second stage constitutes prolongation necessitating instrumental delivery should be a clinician's decision. Now, looking at the neonatal outcome, we'll just see it can be either direct, indirect effect, or both. But overall, it was seen that there was no fetal heart rate change in the non-laboring women for cesarean when we use a very high dose of local anesthetic and the high concentration. So there must be something to do with the fetal heart rate variability and the labor. Now, in the studies done, it was seen that there was no neonatal adverse effect in these two studies, and the significance was unclear. Then coming at sufentanil, it was seen that no serious maternal or neonatal effects were seen, though some variability definitely was seen. Uterine hyperactivity was more with intrathecal sufentanil. Now, this is interesting to see here is that Vandy Velde advised everybody that you should avoid use of intrathecal opioids in case of fetal distress or uterine hypertony before induction of analgesia, and we can avoid it in all women. It is not really required because spinal bupivacaine 2.5 milligram alone can provide acceptable labor analgesia within 5 minutes and for more than 30 minutes, and you can start your PCEA at the end of 30 minutes rather than 60 minutes. And looking at the neonatal acid-base status, it was much better in the epidural group with better Apgar scores and the less need for neonatal resuscitation. To summarize, modern neuraxial labor analgesia is not associated with higher rate of cesarean section than systemic opioid analgesia. Initiation of low-dose neuraxial analgesia in early labor, it does not really increase the rate of cesarean section. Only if there is a dense neuraxial block and complete analgesia, it may increase the duration of the second stage of labor. And maternal fetal factors not the use of neuraxial analgesia are the most important determinants of cesarean delivery rates. Thank you.